Hi, my name is Kelly Stratton. I'm an associate professor of urologic oncology at the Stevenson Cancer Center at the University of Oklahoma Health Sciences Center. Today, I'll be talking about the management of recurrent prostate cancer after focal therapy. Focal therapy has increasingly become a popular treatment for local prostate cancer. And there are several reasons that focal therapy has increased in popularity. There's a migration to earlier detection and smaller tumors. And so we've recognized that not all cancer is life-threatening. And while increasing detection using improved biopsy techniques, we need to have treatment options that suit our patients, particularly those that are focused on quality of life. Patients are increasingly demanding retention of their sexual function and minimal impact on their lower urinary tract as they undergo treatment for prostate cancer. Also, patients want an alternative to active surveillance that is not radical whole gland treatment. Many men find it difficult to accept prolonged surveillance, and so focal therapy offers an alternative for these patients. We also have increased use of prostate MRI and other advanced imaging techniques that really provide a new way to approach focal therapy, and patients are very interested in undergoing these treatments. So the ideal candidate for focal therapy, well, that is sometimes hard to achieve. And that's really because focal therapy looks to try and find a patient who has intermediate risk prostate cancer, who has a localized lesion, who has intact erections and minimal or low urinary tract symptoms. And so that focal therapy patient kind of fits in a very tight window. But that in reality is something that is an artifact, and we don't have to wait for the most ideal patient. There are many patients who are interested in focal therapy and willing to undergo focal therapy. And so part of overcoming that barrier to expanding focal therapy is understanding how to treat patients if they do have a recurrence, because those patients are one of the most difficult patients to become familiar with and really prevent other urologists from adopting focal therapy. And so, again, understanding the benefits of focal therapy is to live in the space between conservative therapy and radical treatment. And in other tumors, this is something that is very commonplace. So in kidney cancer, in breast cancer, and colon cancer, organ-sparing surgery is something that many patients receive. And so prostate cancer shouldn't be held to a higher bar than these other malignancies. There are certainly men who may benefit from focal therapy, and there are some that are going to undergo focal therapy and have a recurrence. And so that is what we're speaking of today. There are many ways to define focal therapy. There are more restricted and then more broad definitions. So here in A, we have kind of a hemigland with a dog leg approach to focal therapy. And so really there's only a small amount of tissue that's preserved. B shows hemigland, and then C and D show truly focalized therapy where lesions are specifically targeted. The rest of the prostate is not treated. Regardless of your definition, any patient that undergoes focal therapy could have prostate cancer recurrence. And certainly we've seen an expansion towards treating as much tissue as possible, but nonetheless, there are patients who will recur. And so in order to really identify the ideal treatment for recurrence after focal therapy, you have to keep in mind the tissues that are treated, the potential for impact on quality of life, and then work with the patient to identify what would be the best treatment option. The primary criticism of focal therapy is the multifocality of prostate cancer. And here is a slide showing a primary tumor on the patient's left side, and then on here on the right is a smaller foci. If this was the only tumor identified and treated with focal therapy, on subsequent biopsy, this contralateral disease may represent a recurrent or a misidentified persistence of cancer. And so this potential to miss occult lesions, particularly those that are clinically significant, is something that is an inherent risk to focal therapy. Now, when we look at tumors, there are nonetheless a large group of patients who may be candidates for focal therapy. So about 40% of patients have truly unifocal disease. Another 21% of those with multifocal have disease only on one side. And so as a combined group, about 54% of patients have cancer that seemingly would be a candidate for unilateral focal therapy. When we speak of recurrences, again, these are in light of our treatment. And so understanding how a recurrence should be treated is predicated on identifying the lesion and then looking at how that relates to the patient's prior treatment plan. So for instance, here, if a patient had hemigland ablation, then a recurrence on the contralateral side may be treated differently than a recurrence on the previously treated side. And so this diagram represents contralateral recurrence. This would be the patient who undergoes focal therapy and then a year or two later undergoes a biopsy, either for cause or as a part of their surveillance program, and is found to have contralateral clinically significant prostate cancer. Infilled recurrences can happen in a couple of different ways. So there could be an area of tissue that went untreated, and so the cancer persists in that area. There are also tumors that maybe weren't sampled, and so on follow-up, the patient has a lesion that grows in an area that wasn't treated before. And in this case, looking at an anterior prostate lesion, those can be very difficult to manage when they recur there, because not only is it a difficult area to treat, but it's also a difficult area to identify. And so a patient who undergoes focal therapy, in monitoring them after treatment, really considering all the different ways that they could fail and tailoring your surveillance to following those areas is very important. So if a patient has an anterior lesion, they may need to undergo a transperineal biopsy. If they have a lateral lesion, you may need to sample that area more intensely in order to ensure that you're not missing something. Serial MRI and PSA are very important as well. So here are some examples of patients that I've treated and some that have had recurrences after focal therapy. Here we have infilled recurrence, or a persistence of cancer. This is a 70-year-old gentleman. He actually had a history of bladder cancer and also prostate cancer. He underwent a pretreatment MRI that showed a PIRADS 4 lesion. At that time, he had a PSA of about 5.1. He elected to undergo focal HIFU therapy. 1 year later, you can see there is a good treatment effect in that area. His PSA correspondingly went down to 2.9. He was doing very well. Then at the 2-year mark, you see that there is some enhancement in that area. And so here you see that margin along the outer bounds of the treated area. His PSA also went up. And so together that was concerning. Biopsy confirmed that there was cancer in that lateral prostate tissue. And so the patient opted for retreatment with HIFU. And so this would be a patient who had infilled recurrence. Here is another patient, had a left-sided lesion seen pre-cryotherapy here. Biopsy targeted to that area showed 5 cores of grade group 2 cancer. This patient elected to undergo cryotherapy. At 6 months post-treatment, the MRI was negative, but we performed a follow-up biopsy and showed persistence of grade group 2 cancer from the medial cores on the systematic biopsy. Now, this patient underwent cryotherapy. This is what I've seen as something that that would be an area that failure of treatment may occur, is medial closer to that urethral warming catheter, you can have patients who are not adequately treated depending upon where their tumor is. This patient was concerned that retreatment may fail again, and so they underwent a radical prostatectomy, and they had an undetectable PSA after 3 years of follow-up. As far as quality of life, this is always a concern for patients undergoing salvage prostatectomy. The patient had erectile dysfunction that was worsened after the prostatectomy, but did not experience any incontinence following surgery and was happy with their results. So this is a patient who has done well following salvage treatment. Here is another example of an infilled recurrence, a 65-year-old who had unilateral grade group 3 cancer on prostate biopsy. This patient underwent HIFU therapy, and so you can see this is a post-treatment MRI where pretty much the entire left side of the gland has been ablated. On follow-up biopsy, they had a single core of low-risk prostate cancer found in the medial tissues on the left side. This patient eventually elected to undergo surveillance. And so, knowing that this was low-risk prostate cancer was not initially the intended target of the focal therapy, this patient felt comfortable continuing with active surveillance. Now, contralateral recurrences, potentially also an occult lesion that was missed and maybe progressed, is something that is, again, one of the roadblocks to wider adoption of focal therapy. So here we have a 51-year-old who had grade group 2 cancer found in a Pyrites 4 lesion, and they had known grade group 1 cancer found from that same biopsy. So in the systematic cores, we found a couple cores of low-risk prostate cancer. Now, this patient underwent cryotherapy, and at 1 year, they had an MRI that was negative. It seemingly showed a good response, but on the systematic biopsies, there was an occult grade group 2 cancer identified. Now, when this happens, Gleason 3+4 on the contralateral side, if it's low volume, the patient may elect to undergo surveillance. The patient could also consider focal therapy to the contralateral side. This patient, being relatively young, was concerned that additional surveillance may provide a missed opportunity for treatment, and so he elected to undergo a prostatectomy. He had negative margins and preserved quality of life and was happy with his treatment as well. So as we look through these examples, all patients who had failure of focal therapy and then either underwent salvage therapy or continued surveillance, it leads us to consider the evidence supporting salvage treatment. And so the most important aspect of salvage therapy is identifying potential recurrences and avoiding a fear of treatment failure. And so what we see from data such as this cold registry, historical patients undergoing focal therapy, that biopsy is not frequently used. And so when they looked at patients undergoing focal cryo, there was about 1,000 patients in this report from the database in 2011, of which only 14% underwent a post-treatment biopsy. Of those, 25% had a positive biopsy. And so if we don't biopsy patients, we may not identify clinically significant cancer. And that's something that is a discussion between the patient and the urologist, and understanding the potential for missed opportunities for treatment. Now, if we look at a larger group of patients over a longer period of time, we see that failure-free survival rates are fairly good. So at 5 years, failure-free survival rate was 88% in this study. And this was over 500 patients, nearly 600 patients. And so those are very positive results. when we look at them stratified by risk, we see that for the most part, recurrences happened in the higher risk groups in the Gleason 7s and then in the Gleason 8 to 10. So if you look here, the top line is Gleason 6 or less. Then we have the Gleason 7s and then 8 to 10s. And you see here that the failure-free survival was much lower in the small group of patients who had high-risk prostate cancer. In those with intermediate risk, which is probably the sweet spot for focal therapy, the failure-free survival was 13% at 5 years, which is pretty impressive. And then those with low risk rarely had treatment failure. Again, when we look at this group, many patients actually underwent retreatment. And so when you're talking to a patient, particularly if a patient is concerned about the finances of the treatment, they very well may feel like retreatment with ablative therapies is not acceptable. And so when you look at these studies, there are groups that frequently perform retreatment. And in fact, in this group, 25% of patients underwent a repeat HIFU therapy. And when you look at that, particularly those with high-risk disease, there was a large group of patients who underwent repeated HIFU therapy. I think that this is something that providers have to weigh in and discuss with patients about whether or not they would want to repeat focal therapy or whether they would want to go on to more aggressive treatments. But nonetheless, whenever we look at the data from these studies, retrospective studies and prospective studies as well, it's important to understand how patients are categorized as to whether they have undergone a retreatment or not, and what that rate is as opposed to more radical treatment. Again, in this study, only 37% of patients underwent a post-treatment biopsy. And so you see that there are groups that undergo or that provide focal therapy without post-treatment biopsy. Now, this is a larger study, over 1,000 patients with long-term follow-up, and looking at retreatment-free survival and radical treatment-free survival. And so as we look into more modern reports, we see this differential between retreating patients and then those that move on to prostatectomy or radiation therapy. And so in this group, at 5 years, the retreatment rate, retreatment-free survival was 58.9%. So nearly 40% of patients had undergone retreatment. And as you look farther and farther out, that increased as well. Now, radical treatment-free survival, though, remained fairly intact. At 5 years, it was only 90%. And so you see that this group reports only a small number of patients needing radical treatment after focal therapy. And some people may consider whether focal versus hemigland ablation would impact the need for retreatment, and it doesn't seem like that it does. So I think from this perspective, where there was no significant difference in retreatment rate between those undergoing focal and hemigland ablation, that this is probably driven by the biology that prostate cancer is multifocal, either in field or out of field. And so as we're trying to maintain continence and impotence or an erectile function, if we don't treat the other side of the prostate, then there's always the potential we'll have retreatment and recurrences. So here we're looking at retreatment-free survival further stratified by Gleason grade. So Gleason 6, Gleason 7, and then Gleason 4+3 or above. So if you look, the retreatment rate is really heavily impacted by those patients with 4+3 or above. And there was actually no significant difference between those with 3+3 and 3+4 as far as retreatment. And so we see that HIMI versus focal probably not going to impact the need for retreatment, but certainly Gleason score may have an impact. And then the functional outcomes following prostatectomy. So many of these patients, if they don't undergo retreatment, then they would potentially move on to more radical treatments like prostatectomy. And there are very few reports about radiation therapy after focal therapy. So it's unclear the impact, although we would expect it would be similar to radiation therapy upfront or primary therapy. There are some early reports on whole gland treatment with radiation salvage, but for the most part, we're seeing reports of patients undergoing prostatectomy after failed focal therapy. When you look at continence after salvage prostatectomy, it is not a lot different than primary prostatectomy. However, the risk of biochemical recurrence is different. And so this is something important and concerning when patients are considering whether they would undergo focal therapy or if they would undergo a salvage prostatectomy at the time of recurrence. And I think that this weighs in a lot on patients who would consider retreatment with repeated focal therapy. We may miss an opportunity to prevent biochemical recurrence with radical surgery if we're repetitively treating patients with HIFU or cryotherapy. And so this is a signal that we're picking up in data for patients undergoing prostatectomy. Now, when we further stratify those by patients who either have an out-of-field or an infilled recurrence, what we see is that those who have infilled recurrences seem to have a higher risk for recurrence. And so, although not clinically significant, this study is showing outcomes for patients undergoing salvage prostatectomy, that the patients who had an out-of-field recurrence, meaning that their cancer occurred on the contralateral side and then underwent prostatectomy, they seem to do better and have less risk of biochemical recurrence than those who had an infilled recurrence and then underwent prostatectomy. So again, this vigilance for prostate cancer recurrence is important, and we don't want to miss patients who could undergo surgery and be cured by continuing to rely upon focal therapy in patients who have failed. So when you look at this, again, it's very important to consider the prior treatment regimen, what it looks like, and then where the newly identified cancer is, and relate them one to the other. In my personal practice, I tried to document as well as possible for myself where the treatment was for all the patients undergoing focal therapy, so that if there was a recurrence, I know exactly how I approached the prostate to begin with, where my treatment was, and then how I may strategize for retreatment. So based off of experience and reports, there have been several strategies for categorizing approaches to retreatment and salvage therapy after prostate cancer recurrence following focal therapy. And so this is a diagram showing one potential strategy. So a patient who has focal therapy undergoes a biopsy. If that biopsy shows low risk prostate cancer, particularly low volume prostate cancer, low volume, low risk prostate cancer, that patient could consider active surveillance as a very reasonable treatment option. Whereas if they had high volume, then you could consider either active surveillance of high volume, low risk prostate cancer, or maybe even retreatment with focal therapy. For a patient who undergoes post-treatment biopsy and is found to have intermediate risk, if it's low volume, potentially consider retreatment with focal therapy. If it's higher volume, radical therapy like prostatectomy or radiation therapy. And obviously, if a patient has post-treatment biopsy that shows high-risk prostate cancer, they should be recommended radical treatment with salvage, prostatectomy, or radiation therapy. So, looking at patients, following their PSA, repeating an MRI, performing a post-treatment biopsy, and categorizing any recurrences, and then reflecting back upon the treatment plan, the initial treatment plan, and then counseling the patient on their options and a potential salvage regimen. All of these things are very important for anyone who is embarking upon treatment with focal therapy. And so this is my final slide. Focal therapy success, it requires an adherence to the principles of active surveillance because we're leaving untreated prostate tissue in all of these patients. It requires follow-up biopsy and a willingness to provide definitive local therapy when focal treatment fails. It's truly the balance between active surveillance and prostatectomy radiation therapy. So thank you for listening in. This is my contact information. If you have any questions, I'd be happy to chat. Thank you.